Hi guys, I'm Dr. Sini Sharma. Today's lecture is about Bppv. Bppv means it is benign paroxysmal positional vertigo. This term coined by scientist named Dix and Holpike in 1952. This benign paroxysmal positional vertigo term coined by Dix and Holpike. This is the common cause of vertigo. Most common cause of vertigo. Most common cause of vertigo and also most common cause of peripheral vertigo. So this is MCQ. This is the most common cause of vertigo and also most common cause of peripheral vertigo. If you see in ENT OPD 20 cases, you will get 3 patients of vertigo, that is peripheral positional vertigo. What is the age preference? Most common age of Bppv is 50 to 70 years of age. Most common in female than males. Okay, what is pathogenesis? This vertigo is two types. Idiopathic Bppv or it is secondary Bppv. Idiopathic means there is no cause, also called primary Bppv. Idiopathic, no cause found. In about 70% of cases, there is no cause. It is just idiopathic. And in secondary Bppv, it may be due to trauma, if head injury or trauma. It may be in a rare disease, secondary to in a rare disease like Meniere's disease. It may be due to ischemia, bacteriobacillar ischemia, or it may be because of infection and like CSM, or it may be because of any degenerative disease like osteoporosis. So this is most common of the cause of trauma. Secondary Bppv is most common due to trauma. Second, it may be found in infection like vestibular neuronitis. Okay, what is pathophysiology? What is pathophysiology of Bppv? If you see this diagram, this is ampullary end of posterior semicircular canal. This is ampullary end of horizontal semicircular canal, posterior semicircular canal, anterior or superior semicircular canal, and this is horizontal semicircular, and this is utricle. This utricle having autoconia, that is calcium crystal, also called autoconia. If these autoconia, pathophysiology, if these autoconia dislodge from here and goes in wrong place, this is the place of autoconia and utricle, and if they dislodge from here and comes in either in posterior semicircular canal, horizontal or superior semicircular canal, this is abnormal location lead to excitation or stimulation of the peripheral afferents causing vertigo. This, if it is in the ampulla, they are free floating. free floating this dislodgement of this utricle calcium autoconia dislodges from utricle into semicircular canals. It may be like free floating. It may be free floating in canal like this green dots. Autoconia, it's called canalolithiasis. They are free floating. If it is attached to the cupula attached to the cupulas of ampullae of the semicircular canal, it is called cupulolithiasis. This theory is given by Dr. Harold Skupnach. This theory, free floating canalolithiasis and cupulolithiasis, given by Dr. Harold Skupnach. This autoconia leads and dislodge in the most commonly posterior semicircular canal, then horizontal, then anterior semicircular canal, lead to vertigo. That vertigo is characteristic for each canal. Okay. Characteristic for each canal. If most common is found in the posterior semicircular canal, then horizontal semicircular canal, then last anterior or superior semicircular canals. The incidence about 97% cases are posterior semicircular canal, Bppv. It may be 2% about and less than 1%. And superior semicircular canal, because of it's less common in superior semicircular canal because of geotropic, this gravity not leading to deposit this ampulla any autoconia. The dependent position of posterior semicircular canal ampullary end or posterior semicircular lead to the most common site of the posterior semicircular canal Bppv. Then 2 or 3% cases may be horizontal canal and less than 1% with the anterior semicircular or superior semicircular canal. Now, this is the incident. What is the classical symptom of this Bppv? Bppv is classical as short lasting spelling or whirling type of vertigo less than 1 minute, which aggravated by positional changes like getting from the bed, rolling in the bed, and sitting up from the bed. So this is characteristic symptoms. In posterior semicircular canal, the characteristic nystagmus are torsional, upbeating nystagmus. Characteristic nystagmus, if you do the testing like disc Hallpike positional test, you will find there will be torsional and upbeating nystagmus. In horizontal semicircular canal, there will be horizontal nystagmus, and anterior semicircular canal, there will be downbeating, torsional nystagmus, which aggravate a particular position of the patient, like getting from the bed, sitting from the bed, rolling, and bending the neck. These are the classical feature of nystagmus in Bppv. Now, what is the diagnostic test? Diagnosis. Diagnostics is consistently done by disc Hallpike maneuver test. Disc Hallpike maneuver test. If you do the disc Hallpike maneuver test, like this is table and this that turn at 45 degree to the testing opposite to testing side. This is the turning at 45 degree to the test opposite to the testing side and make patient supine with head extended from the table downwards like 20 to 30 degree. Independent position like 45 degree. There will be nystagmus like downbeating, torsional nystagmus less than 20 seconds. Duration nystagmus and they are fatigable if you repeat the film. So this is classical on dependent position. If you turn the head 45 degree and make patient supine with slide 20 or 30 degree, neck extended below the couch, you will find the classical nystagmus, that is disqualified maneuver test. If you find this nystagmus any clinical sign of central nervous system, do imaging to rule out any stroke like MRI. If you find any central nervous system ataxia, any neurological deficits, then you should go for MRI imaging. And most important test you can do advanced 3D vestibular neurography. This is technology we can find out particular type of nystagmus and particular type of canal affected and advanced 3D vestibular nystagmography testing. This vestibular nystagmography testing can identify type of nystagmus, downbeating record the nystagmus also. So this is best method to diagnose the Bppv. Now, what is the differential diagnosis? DD. DD, it may be vestibular neuronitis, it may be Meniere's disease, it may be superior semicircular canal dehiscence syndrome, it may be central causes like multiple sclerosis, vestibular migraine. So these are the common disease, but we can rule out these disease by particular testing or episode, particular type of nystagmus leading in particular position by doing test 3D video nystagmography. That is ideal for this Bppv diagnosis or particular positional. This can be diagnosed by clinical testing, clinical disc Hallpike maneuver. Now, what is the therapy? Therapy. The most common therapy you should do in posterior semicircular canal Bppv is you do apnea maneuver. If you're doing disc Hallpike maneuver, then rotate the patient in opposite direction and roll the patient in lateral position, then sit back. Then is apnea maneuver. Then another method is Simon maneuver. Simon maneuver is a patient sitting on couch on lateral side. If your patient turn 45 degree to the opposite of unaffected ear, then patient turn on one side, then make 180 degree to the opposite side. That is Simon maneuver. Like this. This is couch, and this patient is sitting. And 45 degree, this patient turn to the this side, and then you have to do one side this test and patient like this, and rotate 180 to the opposite side. This is Simon maneuver. This is for diagnosis of benign paroxysmal positional vertigo. You have to do disc hall pike maneuver, and for treatment of posterior semicircular canal, you have to do apply therapeutic maneuver or cement laboratory maneuver as shown in this slide. For surgical treatment of posterior semicircular canal, you can do gastric singular neurectomy or posterior canal occlusion by transmustod approach. For horizontal semicircular canal, you have to keep post positioning on a healthy side and your rotation 370-degree, barbecue maneuver 270-degree. For anterior canal or superior semicircular canal, you have to do modified approach therapeutic maneuver. So these are the positioning